So I'm joined today by Professor Hugo Critchley here at Sussex University to discuss his research in the field of neuroscience. Hugo, thanks so much for agreeing to speak to us.
Pleasure.
We've been working together for quite a few years, and I always value our conversations. The whole field of interoception, which hopefully we'll talk a bit more about in a second, I think people will find interesting. It's something that's a bit of a sort of a brain twister, but perhaps you can tell people, first of all, a bit about the work you do, and then we perhaps go on to those topics.
Yes, so I've been interested in emotion primarily and how that impacts psychiatric presentations by way of background, but I've been very focused on how brain and body interact in determining how we think and feel, and how the emotional states of individuals can affect their physical health, as well as how the state of arousal people are in can influence anxiety and other emotional states that can be quite pathological, underlying clinical conditions and symptoms.
I mean, obviously you have a really interesting role because you are still a clinician practicing as a psychiatrist, but also doing a lot of neuroscience research. So you're seeing both ends of it, I guess, from the really basic science side and seeing things manifest in real life. What sort of patients are you seeing?
Yeah, so I currently, for the last 16 years, have been working in adult neurodevelopmental conditions. We set up a service in 2006 in Sussex that was originally a diagnostic service for adults presenting with possible autism, but we extended it to include an interest in Tourette syndrome that I had from working in neuropsychiatry as a neuropsychiatrist in UCLH, Queen's Square for a while, and was a consultant for the National Tourette Service. The person that founded that was off sick, and I did that for a couple of years. Neuropsychiatry is about the kind of overlap between neurology and psychiatry. How conditions that affect the nervous system can present as psychiatric conditions, how psychiatric conditions can present as conditions affecting the nervous system, and there's an area of overlap, and Tourette syndrome is a very good example of where mental state and stress can affect the presentation of movements, unwanted movements, tics and vocalizations, and it's this interesting set of conditions for lots of reasons. Anyway, so in Sussex we set up an adult service for people with autism, tics and ADHD, which actually is attention deficit hyperactivity disorder, affects about 5% of the population. You don't necessarily grow out of it much, it changes a bit as people get older. And all these conditions overlap quite a bit, and one of the first observations we had when we set up the conditions, how much of an overlap we were seeing clinically.
Between autism, ADHD
and tics.
And tics, interesting.
Yeah. Although now the emphasis, and there's been a massive upswell in recognition of ADHD and autism, and actually post-COVID there's been this whole issue around tics and how functional tics might be a thing, which is surprising to me because, to say, the expression of tic disorder is very functional anyway. Kind of the mental state of an individual will affect whether or not they're in a stress state and are moving more or less, or ticking more or less. But yeah, so we set up the service. Originally three people, myself, a psychologist, a speech and language therapist. Now there are about 30 people involved in the service. Wow. Waiting list is years, and massive, as it is for child services for those sort of conditions. Before we started, we were talking about kind of how the clinical work that I do relates to the research work that I do. Actually, to some extent, it got closer because the research had previously focused a lot on mechanisms of emotion that involve body changes, and how the autonomic nervous system that controls the state of, say, your heart beating fast and your blood pressure, how that relates to fear states and anxiety and things like that, at a very mechanical way, but not really applied to clinical conditions. That's now converging, and now we're sort of building from the research into kind of more detailed human studies into therapies that we're now rolling out into particular conditions like autistic individuals who are very prone to anxiety.
And it strikes me that a lot of that work is because there are new tools, new technologies that allow one to take some of the research or monitoring from the laboratory into the real world. Would that be correct? I guess we have more wearables that people can use, or lower cost devices that don't require you to have expensive laboratory equipment.
That's an interesting point. I mean, certainly. So as I say, we said about defining mechanisms through which we can manipulate people's state of bodily arousal or appraisal of their state of bodily arousal, how they perceive their body.
And by arousal, you mean the level at which they are feeling excitement or anxiety. I guess it's a difficult word, isn't it? Because it has
so I'm using it in a very physiological way.
Yes.
So fast, strong heartbeats, for example.
Yeah.
Action-ready states. So things that make you that you call on when you go running and that kind of thing.
Yeah. Just to clarify, because for those who aren't
rather than wakefulness, and the two go together in interesting ways. So you can be alert and unfocused and so there's kind of unfocused mental arousal, if you like, and focused mental arousal when you're concentrating really hard on a task, where you might need to down-regulate the kind of physiology of your body. You don't want to be in a running state when you're trying to focus on something very closely. So the kind of attentional arousal of what your mind might be doing may or may not be coupled with the change in body states. And a lot of the early work that I've done has been trying to understand the brain systems that are involved in adapting the body to the required state for the task in hand, whether it be an emotional response or a mental effort or even an exercise task. Where am I? Yes. So some of these insights that we kind of developed into eventually training tools and then clinical trials. I've sort of been bypassed a little bit by people out there in the real world, clinicians and of different professional backgrounds, telling people to use their smartwatches to look at their physiology to navigate a social situation and realise actually it's not really anxiety, it's just you're excited and your body's telling you it is, and these kind of things. So to a large extent the tools that are being provided by wearables, for example, are being opportunistically used and in therapies rather than necessarily developed for the therapies.
Yes.
And that's really interesting.
In a useful way, or?
Yeah. I think so. I mean, obviously, I'm quite keen to develop a very specific therapies based on what we've done. But as I say, a lot of what we're trying to do is being not bypassed but implemented anyway, with people having greater access to better quality data about their internal states of whatever, of arousal, of stress. People have projected back changing body state to people's mental states through different studies and made these inferences that allow particular smartwatch manufacturers to translate heart rate measures into stress measures and things like that, which is kind of interesting.
So this area of people's interpretation, or at least their misinterpretation of their bodily signals and the consequences, is a big part of some people's clinical conditions.
Yes. I mean, there's strong theoretical models of which which can be very detailed in some cases. I, for example, wonder about whether there are 3 different systems through which your brain knows how fast and strong your heart is beating, and as long as they're aligned, that's well and good. But sometimes you might be over interpreting your body state by focusing on the wrong pathway, if you like.
So the 3 pathways would be what the actual event itself, your heart. The other one is your brain's interpretation of your heart rates?
I think when you're probably at your most healthy and functional, you're not focusing on your body state too much. Your predictions about what your body should be doing and is doing are accurate, and therefore you can discount having to monitor them closely and what have you. There's a model that I use in various lectures that came from David Clark, a psychologist in Oxford, who developed various models of anxiety and panic, where he talks about someone walking along the streets and feeling a twinge in their chest and thinking, that's my heart, I'm going to have a heart attack, and they start breathing faster and sweating more and getting a bit out of breath, and that sensation of the heart beating faster because they're anxious and the breathlessness reinforces the idea that they're having a heart attack, and that leads to a panic attack, which eventually they get through, maybe take a paracetamol, relax, and the next time they go walking or running, they're monitoring their heartbeat for any kind of sign of anything, and misinterpreting sensations that are probably like your ribs moving and a bit of pain on your chest as evidence that they've got a heart problem, and leading again to these panic states that are difficult to escape because they're reinforced by sensations that are initially not from the organ that you think is causing the problem, but reinforced by the arousal and
by the response. Yes,
and then attending to the body response. I think most of the time people are brought to awareness of physiological changes in the body when they're unexpected, and some of that unexpectedness is actually anxiety related. I think anxiety in some models is perceived as being a prediction error, about what your body should be doing, a misinterpretation of, or a lack of being able to assign why you're in a state of arousal to a cause, and free-floating anxiety can develop from a cardiac arrhythmia that you're not aware of, and these kind of things. But
yeah, I have obviously in my work in facial paralysis, in those patients you have, for example, hemifacial spasms, which for our listeners is spontaneous contractions, usually of one side of the face. It could be around the eye, it could be the whole face itself, and which is often heightened with anxiety, but which in itself, for example, I have two patients, both male. About 70% of patients are female who come to our clinic. We have a very large clinic treating facial muscle disorders. These two patients are both barristers and both find this condition especially difficult because at the time when they're doing their closing statements, where they want to be very focused on what they're saying and want the jury to be very focused on what they're saying, that's often a very stressful time, the closing statement, because it's very consequential. The spasms start, and then the anxiety that induces changes the threshold to firing for the facial muscles, and actually it can set up this sort of vicious cycle. And it sounds a bit like that's what you're seeing with Tourette's.
Absolutely, so I'm sure there's a degree of overlap, but very similar aspects to what's going on anywhere in a lot of facial tics. I mean, we talked about research studies actually monitoring this with your wonderful sets of glasses and things like that. I think what we've seen in conditions such as Tourette's is what you're saying there. The kind of physiological response in the body can be, if unpredicted and uncontrolled, it can be a massive distraction and emotional challenge for people to manage.
Yeah, and then but in itself become this sort of feedback loop which causes tremendous difficulties. Yeah, it's fascinating. I mean, the heart rate work that you're doing is really interesting. I think I'd like to talk a bit about that, about the ability of people to sense their heart rate and how that can be applied clinically.
There are two aspects to it. As I say, a while back we kind of got interested in kind of how emotions generate changes in the body, and a typical example is anxiety generates a kind of an escape response, if you like, a fight and flight response through sympathetic drive, parasympathetic withdrawal. So these are kind of fight and flight and rest and digest systems that work antagonistically. So you take away the rest and digest, your heart rate goes up. You add more adrenaline and noradrenaline, and your heart rate goes up further. And that's kind of an anxiety stress response. And we're trying to map, how that's generated in the brain by emotions or appropriately with exercise and cognitive effort. So we're looking at the brain responses to body or cardiovascular arousal, faster, stronger heartbeats, and the way that's regulated in terms of inhibiting reflexes that normally keep your blood pressure and heart rate fairly even. Related to that is the notion that people perceive these changes, and that adds to feeling states like anxiety. So part of the feeling of being anxious isn't just the kind of mental fear that you get of what's going to happen. It's reinforced by these sensations of your heart beating fast and strong and your breathing changing.
And wasn't there some relationship between that and certain almost collagen types, where people have relatively flexible tissues and therefore they have blood vessels, for example, that may change a lot with heartbeat, and therefore they may sense the changes more?
So you kind of racing here, I just want to say that the two bits of the kind of cardiac interoception, so interoception being the whole of that signalling and representation, and the cherry on the cake is the perception of what's going on. It's one part of it, so one part of it is just what that stronger, faster heartbeat is doing to the way you think and feel, irrespective of whether or not you're actually feeling your heartbeats. And the other thing is whether the individual is more or less sensitive to perceiving body changes, including their heartbeats. And the two things have gone in parallel streams of research. And then you have clinical presentations or even differences, and 20% of the population are quite flexible in terms of their joint tissue, allows the joints to move quite
hypermobile sort of thing.
Hypermobile. But that reflects a more general difference in how other bodily organs, the tissue, the connective tissue in other body organs functions, and so there's a set of conditions called dysautonomia, where people show, for example, their heart rate races much more than people without the condition when they stand up, and it stays elevated. And it's thought that this is a result of a failure for the a kind of pooling of blood in your legs, because the tissue's a bit more compliant and less elastic.
Yes.
And so this condition's generally seen only in people that have this hypermobility features. Again, it's really common. 20% of the population probably are kind of more flexible than the other.
And is it correct that more females than males? Is that correct, or not? Yeah.
Okay. Which brings in another set of questions, but which are of interest: the role of steroid hormones, which not only cause the ligamental laxity that is necessary for childbirth and that kind of thing, but steroid hormones are also part of stress responses and responses to trauma, and there may be critical periods of vulnerability. Where you have childhood trauma, you might be posed to developing damaging or developing types of connective tissue organ interactions that might affect future emotional behaviour if you think this is the driver for it. But there's some interesting questions that can be thought about.
That just actually sparks in my brain, because one of the things that we talk about sometimes, and it's borne out in twin studies, how stress has an impact on how one looks, for example. And we also know that people who are on steroids, for example, for other conditions, has a terrible effect on skin quality. It kind of ages the skin. It causes obviously distribution of bodily fat as well, which is not very helpful. And as a plastic surgeon, I do see people who have had I recall a lady last week. She had to nurse her father for 5 years through a very difficult death, and she said how it aged her by 10 years, and she noticed it on her face. And I do wonder if there's a relationship there between the role of stress, the stress hormones, and its impact on the bodily tissues, and then how that manifests externally as well.
Yeah, I think it's a really interesting question. So I have been wondering, because when we see clinically sort of people presenting with problems related, say, to ADHD or autism, does crop up at particular life points, say, menopause and pubescence and things like that in women particularly.
I mean, one of the things that strikes me as being, so my sister, who was a year older than me, she's sadly not with us anymore, she had schizophrenia, but so she was diagnosed at age 12, and so I had this sort of indirect contact with the mental health system for a long time, and it did strike me as there's a big disparity between how, say, other conditions like cardiovascular disease and metabolic diseases are managed, because we have tools to monitor the effects in the body, but we're still largely focused on sort of survey, self-report questionnaires within a lot of psychology and neuroscience work, which is something that I think has held the field back in a way, because people's memories are incomplete. We tend to remember things that are more recent than more distant. We tend to remember things that are more salient, more emotionally stimulating than less so, and so things such as changes in heart rate on activities, for example, and how you relate those to stress would seem to be something that would be really valuable to be able to understand conditions and to be able to group patients into certain subtypes, so you could do more focused research.
I mean, there's obviously been a lot of impatience with the progression of biological psychiatry in various ways. We haven't really got biomarkers for many conditions. Obviously, dementias and things like that are increasingly being handed over to neurology almost by virtue of actually finding these things, and psychiatry is often focused on symptoms as part of the syndromes, and so while you can have cancer and not have any symptoms or something like that, you can't have necessarily a psychiatric disorder without either symptoms or signs that relate to the mental state of the individual, because by its own definition. I think what you're getting at though is that we can personalise and stratify conditions if we have a much better knowledge of it, and I quite like it, because although we've focused on conscious perception of emotion and expressions of behaviour and psychological symptoms, I do think that behavioural measures are really important here, and all of it ultimately originates in brain-body systems that express how people behave and interact, and both socially and individually. Yeah.
I mean, it strikes me that we often distinguish between symptoms and signs. So symptoms being the thing that the patient reports to the clinician, and signs being something that's observable. But presumably, all symptoms, if they are meaningful, will result in some change in behaviour by definition.
Yeah.
If they are truly relevant, they have to. Even if the behaviour means not doing something, it's still a change in the expected behaviour for a person. And so having better tools to monitor behaviour would strike me as being a really important part of moving the field forward. But we digress.
No, exactly, because I think what you're saying about hypermobility and the model that we have about how that might influence emotional state, by virtue of changing the way in which cardiovascular response to the periphery affect things like anxiety. I think your interest in facial expressions is really pertinent, and also links to autonomic control. There's been evolutionary models of how bronchial arches manage facial muscles that relate to autonomic nuclei that control heart rate and blood pressure and things like that. So I think these things are tied together, and people like Stephen Porges is an influential psychophysiologist, I guess, as proposed models of how heart rate variability and facial expressions interact, how hearing and smiling interact, and how that can be harnessed potentially in therapies for improving function in autistic children, for example.
Yes. Yeah, that whole field of autistic children and being able to understand earlier on enough. I think you mentioned something about the delays in diagnosis being people taking a really long time to be diagnosed, and that the diagnosis mostly is based on observation and questionnaires, presumably.
As you know, you need a detailed clinical evaluation, a proper clinical history to make a diagnosis, and it isn't just a tick box questionnaire thing. Although, because of the demand and increased recognition of the spectrum, if you like, of autism and ADHD and related conditions, and the recognition of how people struggle through, but could do much better if they had the right adjustments and support. There's a pressure to get more people diagnosed as being an underdiagnosis problem, I think, and therefore there's also a pressure to get self-diagnosis recognised, or people doing rapid diagnoses with clinical interviews that are doable within an hour or stuff like that. It kind of takes away a lot of what you would hope would be a very thorough assessment that will define all the problems and focuses on one condition. It's very difficult to get kind of thing we offer in our clinical service, which is a big multidisciplinary perspective, or maybe not in the assessment itself, but the culture is one that we would look at autism, ADHD, other conditions, including physical health stuff and traits like hypermobility, together as a package, and to understand the individual and their navigation of not just social and occupational environments or educational environments, but also the health service itself, and how they might be presenting to their GP or to other services with conditions that are part of the same package. The kind of interactions between physical and mental health within that neurodivergent population are quite interesting. Partly because the sensory expectations of the doctor of what is potentially the normal experience or expected experience of an individual might be quite different in someone with an autistic individual and other conditions, because they may be more or less hypersensitive to different types of stimuli and situations.
Yes. Yeah. When I read the King's report, the economic cost of the condition is, apart from the tremendous suffering for the individual and their families, the economic cost of the condition is 30 billion a year in the UK alone, which is staggering, and a big chunk of that is due to social care, difficulties getting a job, even for those very high functioning, who are very, very bright and capable, but just not being able to get past go in terms of even the job interview and the like. It's really, really tragic, and that the condition is so under-recognised, and that we just have so little resources devoted to it.
Been reading around those things, I'm aware that people are even challenging the fact that you should define conditions by capitalist economic value. If you're seeing that people are underperforming economically, then that may not be the right model to look at a condition.
No, yeah, I guess it's more about saying, okay, well, how can we make governments really take notice of these things and put resources in?
Sure.
Because it's clearly what's been in the past hasn't worked, because the waiting lists are growing. Diagnosis may be bad, but treatment seems to be even worse in terms of what can be done to help people to live a life that they want to live.
Yeah. And it's becoming less about treatments and more about enabling people to get the kind of recognition and support that they need.
Yeah, again, and being able to fund that support, it has got to have some kind of a a value put to it, and so that's I guess that's how it seems to run. It seems strange to put costs on things, but within any health service, you'll see that there's a constant decision around what treatment will get funded and what won't be, because if there's a certain pot, then they're going to compete in some way, which sounds very harsh, but it's just the reality of health services. My condition that I treat, facial paralysis, is very much about quality of life, because regardless of whether they've come through via a tumour or an accident or an infection, it's really now about how they feel. Of course, there are some functional things to do with being able to close your eye, to sleep and protect it, to be able to eat and drink. But beyond that, it's about the impact of how you look on how you feel, and how you feel can actually affect you in another tangible way, such as people giving up work because they don't want to be front-facing in the hotel or the job, or as a presenter or as a teacher, and people give up their roles. That has a tangible impact on their economics, which has an impact inevitably on their health as well. So, but then we fight for resources for those patients, and it's a difficult fight because there's somebody else who's got, I don't know, chronic constipation and is having treatment for that, and that condition is largely preventable through diet and exercise in many cases, or a combination of things. Whereas these conditions for many patients aren't. You can either be born with facial palsy or had it impacted on you. And so we do a lot of work trying to show the economic impact of facial paralysis on the individual via its mental health consequences. But it's a different one.
I mean, I think particularly, as I say, there's been this big surge in terms of the neurodevelopmental conditions being diagnosed, recognised, and people wanting not just the diagnosis and on 8-year waiting list or whatever it is, but then something done when they've had the diagnosis beyond saying, this book will help you understand yourself a bit more, or maybe that's an explanation of the struggles you've had. It's an interesting time, and in relation to that, there'd been sort of evidence for a while to suggest if you treat ADHD, then you avoid people getting into problems later on. They progress through college, they don't get into prison and criminal justice systems and this kind of thing. But actually, that data's old now. We need to relook at it and see what the advantage, because there's been last few years such a growth in the number of people receiving treatments for these conditions, and people are sort of saying, it didn't happen in my day, or whatever it was, what's going on, kind of over-diagnosing.
Do you think that?
And I don't think it's there. I think we're kind of recognising and enabling more people to get on with things, and it's even society's changed a bit. So even the context of what we're doing is different from perhaps what it was. And yeah.
Do you think that digital tools, the digital age, has had an impact on people's behaviour around attention, focus, distraction?
No. I mean, briefly, I know. I mean, I've been. I can remember attending a conference in 2004 or something like that, where
it's pre-iPhone.
Someone was presenting presenting the argument that basically, the youth of today with video games are giving themselves frontal lobotomies. And it's the same story. I don't think it's true. I think things are different. To how they were. I think the measures are different. The context is different. What the the models of how you learn even now are different, and how it's then applied to I don't know what you call it, functional achievement or something like that. I mean, that's shifting quite a bit as well. So I don't think that the digital tools that and games and exposure that people have now is particularly detrimental. It may obviously open up areas of worry and concern and risk and all these kind of things, so that cyberbullying and exposure to vulnerable people to things that make them more vulnerable, or enhance particular conditions, for example eating disorders, pro-anat type stuff. And a whole thing around pornography and whatever it's called, toxic masculinity and all that kind of thing are very rightly kind of discussed and thought about, and tech companies are kind of fighting to some extent or debating as to who should actually take responsibility for these things. But,
In terms of your field, what's your hope for how things could improve? Both in research, but also putting research into practice, so that we can tackle some of these big problems that are affecting people.
So I'm going to ignore the last bit because I don't know what you mean by big problems affecting people, because there's lots of wars going on. There's
let me rephrase
capitalism around the world.
Yeah.
All this
let me rephrase that.
But what do I think is interesting in terms of the tech development stuff with respect to clinical conditions?
Oh, wait a second.
For that question, reset.
Reset again. Okay. Yeah. So, what are your hopes for how your patients are impacted by their conditions, and what research can be done, and what things can be put into practice to help them?
I think we're understanding more about systems of that underpin emotion, that allow people to better regulate emotion, that can be potential targets for treatments. Some of them are coming through serendipitously, like the realization that drugs for appetite control or historically diabetes now might impact people's urge to take drugs or whatever it is. So it could be applied to addiction and other kind of related disorders. So the things that are coming through from understanding brain-body interactions that are within a tradition of psychopharmacology, but kind of repurposing based on knowledge about those systems and then observations about how things generalise. But from getting a really detailed mechanistic understanding from both brain and body, one can think about a whole range of new ways of intervening and helping people to manage symptoms, manage situations. Examples being the kind of vagus nerve stimulation, kind of electroceutical intervention for epilepsy, originally shown to improve mood, used as treatment for mood disorder. Now people are looking at non-invasive ways of delivering similar kind of therapies through ear stimulation, or stimulating part of the ears that wire up with the same pathways from body to brain and influence similar emotional systems and cognitive systems. And the kind of then training interventions and treatments where monitoring people's physiological responses, not just their behaviour and their tick box answers on questionnaires, allows a much fine-grained control or capacity for people to change probably quite enduring symptom patterns or ways of thinking and feeling in a positive way, without necessarily having to work too hard, because that's often a big ask for people with psychological distress. Is you kind of say it's like 1.8 people referred to talking, 1.8 million people referred to UK talking therapies, of whom I think 600,000 actually complete a full course of treatment. So so you've got a massive drop-off rate of people that need support for anxiety and depression. Some may get better before they actually get offered a treatment, but even those that start the therapy, at least half of them don't complete the therapy for various reasons, presumably because the talking therapy isn't the right therapy for them. So it's kind of a 30%, 50% recovery of people that start the treatment, 30% of people that are referred probably finish the course of treatment. And that's not really a good enough alternative to medication, and many of them are on medication as well. So it's kind of, what can we offer to help people get through the kind of psychiatric and psychological conditions that are really holding them back. And I think the sensor technology advances, the digital advances in processing data, and just the kind of growth in science at multiple levels, from the population level observation of deep data dives and it's enriched by all these extra measures. I think there's a lot of hope in the future that we can do very targeted and effective therapies for people that can be individualised for that individual.
You mentioned a while ago about the vagus nerve, and obviously so vagus nerve is obviously very important in digestion, and there is a branch of it that goes into the ear, which is why I think you mentioned about doing peripheral stimulation of it. I guess the facial nerve is another one that has a connection to the brain. There's obviously the emotional centres, and you have this voluntary ability to obviously eat and wink your eye, close your eyes, manipulate food with your mouth, but also the spontaneous aspects of it. There was that work that was done back in the 80s, and I think which was replicated a couple of times around the relationship between the face and the facial movements and the brain, and certainly brain states, or how we appraise things that we see, things that we hear, etc. That's quite an interesting potential avenue, I guess.
Kind of jumped around a little bit. The vagus nerve is a really important nerve. 80% of the fibres come from body to brain, 20% sort of control organs and the gut and the heart, slows the heart down, and this kind of thing. And there is this little branch that innervates the skin of the ear, so it's sensory fibres from the skin of a little part of the ear that isn't present in everyone. And branches around, and some people, anastomosis with the facial nerve and goes in through the facial nerve route, and these kind of things are kind of interesting because people are targeting that as a non-invasive way of stimulating that kind of body pathway into the brain to control emotional systems and maybe attention and maybe epilepsy and maybe even heart problems. But you're right, that is only one of the cranial nerve sorts of pathways that can influence physiology, and we got quite interested in trigeminal cardiac responses. So while we're kind of, the stimulation of the vagus nerve, and particularly that branch is sensory, it's trying to influence the pathways into the brain from the body, you can also, stimulate the tip of the nose or whatever and generate a slowing of the heartbeat, or you can press on the eyeballs and slow your heartbeat. The eyeball one is a kind of vaguely mediated reflex. The diving reflex is also vaguely mediated, but the thing that's driving it into the brain is from the trigeminal branches of the trigeminal nerve. There's, I think, some facial cardiac reflexes. When I do eyelid surgery, and I have to warn the anaesthetist when I'm going to be operating around the fat around the eye socket, because you can get quite rapid drop in the so
heart rate.
So we got kind of interested in, it's a nice acronym, which was HeartMap, so harnessing evoked autonomic reflexes to modify affective processing or behaviour or whatever. By looking at whether we could do things like for stimulating below the eyes, slowing heart rate down in a way that could also then present stimuli in the context of a slowed heart rate. So conditioning the processing the stimuli to different changes in the body that induce the electrical stimulation, and, in the way that people are now looking at how you can link in closed loop ways the vagus nerve stimulation to other things. So it's kind of very short term biofeedback. You don't have to do any effort like get better or drop a thermometer that represents your heartbeat or something like that. You can do these kind of interventions. So I'm very interested in what those kind of things will offer for people, but we need to step through it slowly. Going back to what about the heartbeat perception stuff. I said there's another bit of it. It's not just about how you perceive your heartbeats, it's about the actual heartbeats themselves. If you're in a state of high arousal, your heart's beating fast and strong. If you're in a low state of arousal, it's kind of beating like that. and every time your heart beats, blood goes into the great vessels. It activates these receptors that go up to the brain, and if that particular heartbeat is particularly strong, then you get a slowing of the next heartbeat through the vagus nerve. It gets a baroreflex response. But that baroreflex activation, so every time your heart beats, it does a bit more than just control the next heartbeat. It's represented in the brain as a signal of the strength and time of the heartbeat. We've shown that other people have shown that over a number of years that kind of signal inhibits processing of pain, so that you know if you're in a state of high arousal, you feel less pain, and inhibits other kinds of processing. You can't sort of remember things as well and see things as well. But our research also showed it enhances fear and threat processing, so it does the opposite for fear and threat processing, and lots of a few accounts for why it does that. But this was a discovery that we thought we could harness. And for example, if we did a study a while back where we showed people's spiders at different phases of the cardiac cycle. We present a spider when the heart is making a beat is processed differently than if you present it between heartbeats.
Wow.
It's more threatening. It's more that kind of thing. We showed it with facial expressions. We showed it with the perception of fear faces. That you could tap into the system that's communicating arousal of the heart to the brain without even being in a state of arousal. So you don't have that kind of perceptual overlay of it, but we can still tap into that system. And so with the spider phobia thing, we had a clinical trial where we started off, presenting for one group spider pictures on the computer screen just when the heart is making a beat, another group between heartbeats, and the third group randomly. And the first iteration of that, we showed actually we present the spiders on the heartbeats where it's processed more and initially quite fearful. People seem to show a bigger decrease in their fear response to spiders over time as kind of a part of an exposure therapy.
Yes.
But half that group dropped out because the spiders were much more
too friendly.
So we redid the study and incentivized people to stay in the study and actually did it a bit more efficiently and didn't lose people from the different groups, and again showed that everyone improves when you see spiders in an exposure therapy task, but the people that improved most were people that saw the spiders contingent on the heartbeat, and actually the people that improved most out of that group were the people that were least good at perceiving their heartbeat. Actually, it's kind of an interesting effect, interaction between how your mind predicts and consciously perceives your physiology and the actual physiological responses. Which is why, going back, I think you can dissect out the conscious perception of body changes and how it interacts with actually what's going on in your body in various ways. Sometimes that gap between your predictions and expectations and conscious representation of body change and what's actually happening, that's the cause of symptoms, and we've shown that relates a lot to anxiety symptoms. But sometimes that mismatch gives an opportunity for learning and changing people's behaviours and responses. And so we've now got a bit more interested in changing people's conscious perception using false physiological feedback and things like that. So we've moved from auditory stimuli where we can trick people to thinking they're in a state of higher arousal or lower arousal than they are, to using somatosensory stimuli.
I see.
Studies going where we're giving people false sensations of heartbeat.
Yes. That's interesting. There's a device, I'm not sure whether it's using that technique, called Apollo Wearable. I don't know if you've heard of it. It's sort of Apollo Wearable, and it's a device that does haptic feedback.
We used one called Doppel as part of a study, or we did a study based on one called Doppel that was on the wrist, but actually think we're now moving to chest stimulation,
right,
as a model for that.
Interesting.
But it's an area that I think will be quite interesting as time goes on. And ultimately, actually, if you want people to use these kind of things, you either embed it into clothing or get people to have it on linked to their phone in their pocket or something like that.
Somehow wearable. Yeah, but it's difficult, isn't it? The big challenge is how do you get good quality data, good quality feedback, given that it may be in a baggy clothes or it may not be clothing that has a pocket. Wearable seems to be a way forward in many respects, but it all depends on what is it you're trying to sense.
And change,
yeah. So what's your ambition then in terms of, what would you like to see in the world for the people that you see as patients and in your clinics? What would be the one thing that could really move the needle for those people? Either in terms of a research tool that could help treatments become better targeted, or in terms of some sort of intervention.
I mean, the shift that we've been trying to be part of is a kind of moving away from particularly in the autistic individuals that we see in the neurodivergent group, where people's emotional language and perception of emotion may be different, and they may not be well suited for the classic sort of, you've been ignoring your emotional state type thing, get better at being emotional. We're seeing a kind of a value in using much more body-based interventions and explanations even for this, which is which I actually think there has been a lot of over-expectation that people can think and behave and change in terms of their emotional language. That's underpinned a lot of psychological therapies, and the other alternative is just give people medicines that will lift their mood, and there's not a joining up of those kind of things, and I think I think there's a middle ground that's been proving to be very useful. So say, people that look after people with functional neurological disorders, so paralysis, that doesn't seem to be based on nerve damage and things like that. Teaching them about things that relate to body-based models of emotion and arousal and attention seems to be quite a valuable model, which doesn't blame the person in the way that some therapies seem to.
Yes.
It doesn't necessarily expect a lot of effortful emotional work behind getting better, but it sets out a potential model and a path where people can follow, and part of that is look at your watch, you're in a state of really heightened physiological arousal. As you become aware of that, then you may be able to adapt your behaviour to manage that better, or at least that's an explanation for why you're feeling you are, and you don't need to panic about it.
Yeah, that's interesting. I think the same occurs, just in the same way that people aren't necessarily aware of their heart rate or what their physiology is doing. The same occurs with facial expressions. People often are unaware that they are, activating these muscles here, apart from being responsible for things like tension headaches, and we know this because if we enforce relaxation on them with Botox, it improves, and it's very effective at improving things like that. It also has an impact on how people perceive. That's the work that's been done on the facial feedback stuff, and it's a small effect, but it's a real effect, and that's been done in multi-sensory.
So I had a PhD where we did a lot of imaging studies on facial feedback, facial perception, facial mimicry. Showing that when you smile in response to someone else smiling, or when you activate particular brain systems that one would expect involved in changing emotional behaviours and those kind of things.
And it works.
These were looking at the mechanisms in the brain through which facial mimicry, automatic facial mimicry, operate, but we'd also looked at other facial signals. We've done studies using corrugator muscle measurements, which seems to be better than your smiling muscles as an emotional signal. and again, more about the brain mechanisms that seem to be supporting that facial feedback. The idea that facial expressions are part of the experience of the emotion. So smile and be happy is part of the story, in the way that having your heart beating fast is part of the anxiety story.
Mm-hmm. Do you think there's a role then, that if you had glasses that could give you that feedback, the mismatch between, say, how you feel and what your face is doing, or in reverse, what your face is doing and then subsequently how you feel? Do you think that could be valuable for people in the same way that people are using heart rate measures?
That's a really interesting question. I haven't really thought about that. I mean, people do, the classic, resting bitch face type thing is often something that people recognise might be an issue, and why people aren't responding in a particular way that they might have hoped to an individual, and to some extent having a bit more insight into that is often valuable, even if it's just to diminish their own anxiety about how people are behaving around them.
I find it fascinating because I see it in patients with facial palsy where if they've had so people who lose expressions typically on one side, they often avoid expressing because when they express it exacerbates the asymmetry, so they tend to try to
certainly I've had family members that have had Bell's palsy, but recently I was at an academic place where someone who we collaborated with had a facial palsy, and I was told beforehand, I haven't seen much of him around because he's got facial palsy, he doesn't want to be seen. And we did meet up, and it got a bit better. But certainly, people get really avoidant. But what had historically struck me about people with facial palsy is actually, I think, the link to depressive symptoms, and it's really strong. It's stronger than one would expect from the appearance, stronger than one would expect for the appearance in the context of social embarrassment and reactions and things like that. And I think there must be something intrinsic there which goes back to links between facial feedback and emotions. And
I think so. I think so. I mean, we haven't yet studied this because it's very hard to study, but when we do a muscle transfer or nerve transfer, and part of the treatment to improve the outcome is to get patients to smile, to actually learn how to reuse that muscle, we see improvements in the patient's mood that can't be due to the improvement in their aesthetics because it hasn't really happened yet. It's still part of the process. And so the act of actually requiring them to smile seems to have its own almost independent effect on a person's mood. Obviously, the face is something that is part of a system because you can't see your own face, and for most of human history, we haven't really been able to see our own faces. Apart from obviously the use of smartphones and mirrors is very new. But the fact that you're not smiling means that you're not going to see other smiles from other people. And so we could talk about a neutral face, but a face isn't really neutral if you walk down the street and somebody smiles at you and you don't smile back. It's seen as negative to them. And so that may well also have that role in social aspects of low mood and social avoidance. And it's a huge issue. How society treats people they hate the most is to put them in solitary confinement, and what happens to people with facial palsy very often is that they confine themselves away from other people, and that clearly has an impact on certain people very negatively.
What you're saying about the default sort of expression is kind of, I wonder if you can't change someone's face, they'll have a fixed palsy, whether you would try and bias it to a slight smile. It goes back to, I remember Tony David, who's professor of psychiatry now in UCL, but was in King's, used to do studies on facial expression back in the late 90s, things like that. And rather than comparing sort of happy and sad faces to neutral faces, they'd make the neutral faces slightly smiling, slightly more positive. And it relates to a study later where I was being asked about, what do you mean by intensity of neutrals? and it's sort of saying like you go into a room and everyone's got a really neutral face. You think, what's happened?
Yes, yes, exactly. This idea of neutral is really misleading because neutral isn't neutral. It depends on the context.
Tony David at the time, from what I remember, and I'm not misquoting him, but was talking about the Tony Blair effect of smiling being slightly dominant, slightly, there's a kind of another attribute to having a sort of mildly positive expression.
Yes.
That was made a kind of default neutral face slightly positive, right? Or rather, a standard neutral face more negative than you'd expect.
Yes. No, I mean it is fascinating the role of the face, because it's so connected. You know, anyone could walk down the street today and actually do mind control. You know, literally a stranger, you smile at them, and chances are they'll smile back at you.
And I use that often, when talking to people with tics about contagious tics and the tendency for people to have automatic avoluntary movements. I think that's a term, or involuntary. But we a while back, I mean, it's not just facial muscles, I guess. We've got interest in people's size, and one experiment that I thought would be the best one out of a series of them that we did was basically it's a brain imaging experiment because we're interested in emotions and pupil size. Was to rig up a big pair of eyes on the screen to the person's own pupillometry measures, so measuring someone's dynamic changes in pupil.
Being reflected back to you.
And showed that actually when the movements of the pupils, which we did have sort of grey screens, black screens, white screens before we then presented the eyes, so we kind of recalibrated it each time. But if what the pupils were doing on the screen was the opposite of what your own pupils were doing, seemed to activate the brain regions that are now being sort of talked about as salience network. They seem to be more interesting to the brain than if the pupils on the screen were doing what your own pupils were doing.
So it's like a prediction error, sort of.
It's a prediction error. It's lots of, and it says a few things. One, that your brain's got a representation of its own pupils, which is kind of think how that works. Well, it's just the light coming in into the back of your eyes. It's you kind of think about why would your brain be more interested when so if we're talking and being expressive and you talk about sad things, people get smaller. Talk about pleasant things or exciting things, pupils get bigger, and then suddenly a cloud goes over and both our pupils change at the same time. That's normal stuff. But if suddenly I'm talking to you and then I drift off, you'll notice it. There's something about the eyes that shows that I'm not attending to things. And we use that kind of thing in other experiments when we're doing mind wandering studies and things like that. See whether there's a signature of people drifting off task or minds wandering to other things.
So that's really the mind. The eyes are windows to the soul, or at least windows to your awareness or your focus.
So I do think that, and again, the kind of, it's part of the facial response, but it's a different axis, and therefore there's opportunities for mismatch between the face and the eye. And these kind of things, which again can be deliberate, it can be something related to symptoms and or responses.
And could that be partly why, for example, interactions that are nominally face-to-face, such as over Zoom or Teams, Google Meet, whatever, can be difficult, or at least people seem to find it complicated?
You get some software now that you can make it look like you're watching the screen but are actually doing something.
Yes. I think that is the case.
But I do think,
Jeremy Bailinson did some work around this, I think during the pandemic, because people were finding that they were getting just really cognitively just exhausted by doing back-to-back meetings, and part of it was that there's something about the signal you're getting off the screen that it's insufficient. It seems to be a face-to-face meeting, but clearly it isn't, either because there's a mismatch between where the person's looking and you're looking at them, but you're not looking at them really because you're looking at the screen and their eyes are elsewhere, and you've got your representation of yourself in the screen.
When I was younger, I did think about this, but pre-Zoom and that kind of thing, thinking that it would be applied to space colonisation. So the communication across big distances meant that on screens, and you need much more exaggerated emotional expressions, sort of bigger noses, wider eyes, neotenized features, or physical adaptations to enhance communications in the context of, slightly delayed and distorted signals or lower quality signals.
There's that theory, isn't there, around why is it that we develop some of the features that we have? I mean that the whites of the eyes allows one to indicate to others where you're looking, and it's something that is important for shared attention. For example, the white teeth against the lips again allows you to at a distance communicate that maybe you come with no ill will, because as we know with hunter-gatherer groups, one of the most dangerous things you can do is to encounter a stranger from another grouping, as you see in places like Papua New Guinea, for example. The eyebrows themselves, again, being able to communicate anger and frustration. I mean, some of this may be sort of pop science, but it does seem peculiar that we seem to have evolved these things that become. I mean, why is it not something else? We have these signifiers that appear to be easy to see from a long distance and seem to be preserved.
They're just the gilded.
The girl, yes, that means.
So she's been philosopher and theoretician about emotional scientists as well, and she would argue that facial expressions and things like that are only kind of up to about 50 yards, and everything else is body expression, body posture, that kind of thing, and shown that challenging the kind of basic emotion theory. I think Lisa Feldman Barrett also shown this. If you put an angry face on a positive body, it looks like you're victorious or something like that. These kind of things. Interesting interactions between different systems that add more depth and meaning to models of basic emotion.
Yeah, exactly. Clearly, it's all about everything has to be put into context. It isn't just the face by itself. We can. I think even Ekman himself, he did some studies where he put the face on different bodies and communicated a completely different thing. Disgust becomes rage when you have a raised fist.
I thought, I didn't think. I thought that was a bit at the Gelder in that scene too, with Ekman faces.
Yeah, maybe it was, but it's fascinating. Listen, Hugo, thank you so much for this conversation. Very wide-ranging. The range of topics that you're so knowledgeable about is vast, and it's always interesting. I always find our conversations very, very inspiring, and sends me off to look at another 10 papers that I hadn't seen before. So thank you so much.
Well, thank you very much. I hope to continue to have conversations like this with you.
Thank you.
Lots of ideas I'm sure you have, and we can join up for the benefit of patients and public.
Thank you.